name is Wesley Epplin. I'm the Policy Director at Health and Medicine Policy Research Group, and I want to welcome you all to the Chicago Forum for Justice and Health Policy, an international perspective on lessons from COVID-19. I'd like to do a land acknowledgement. Health and Medicine recognizes and acknowledges that we live and work in the land of the Peoria, Miami, Kickapoo, Potawatomi nations. These lands were the traditional territory of these native nations prior to their forced removal. They continue to carry the stories of their struggles for survival and identity today on these and other lands. As an organization located in Chicago within the state of Illinois, we are obligated to hold these histories and contemporary struggles in our mind today as we talk about community, belonging, and health. A few housekeeping notes. This forum is being recorded and will be available afterward. We will share materials following the forum with you via email. Please also sign up for Health and Medicine's newsletter to hear about upcoming forums and events. You can share your information in the chat if you'd like, your name, gender pronouns, title, and organization, and say hello to the others who are joining us today. Please place any questions in the Q&A section and not in the chat. That'll help us with managing the Q&A. So you can save those for the latter part of the session, or if something comes to you during the talk, it's fine to go ahead and enter it there. So today's forum is part of a series focused on COVID-19 at international, national, and state and local levels. So we have today's event on July 29th. August 26th, we have another coming up that's going to provide the national perspective, and will feature Jose Ramon Fernandez Peña. He's the Director of Health Professions Advising at Northwestern University and President of the American Public Health Association. So that's going to be a great talk. We hope you'll join us for that as well. You'll be receiving an invite for that in the days ahead. And September is still in development, but that will feature a state and local perspective. We want to thank our forum sponsor today, Blue Cross and Blue Shield of Illinois. So thank you for supporting today's forum. A little bit about Health and Medicine Policy Research Group. If you're not familiar with the organization, our mission is to promote the health of all Illinoisans by advancing health equity. You can follow us on Facebook, Twitter, and LinkedIn at the links on this slide, and you'll be receiving updates from us since you're registered for the forum today. We're also celebrating our 40-year anniversary this year, and we'll have our gala coming up on Thursday, September 30th. We have 10 wonderful awardees to be honored at that event, and it will be both virtual and in person. So we hope you'll consider joining us for that. You'll be receiving invites for this event as well. Now I'm really pleased to introduce our speaker, Dr. Matthew Cavanaugh, the Director of the Global Health Policy and Politics Initiative at the O'Neill Institute for National and Global Health Law at Georgetown University Law. And our moderator today will be Dr. Linda Ray Murray, Health and Medicine Board Member and former President of the American Public Health Association. With that, I'm going to turn it over to Dr. Cavanaugh.
Great. Thanks so much, Wesley, and Dr. Murray. Thank you for having me, and look forward to the discussion. As Wesley said, I am the Director of the Global Health Policy and Politics Initiative at Georgetown University, where we are trying to look at the ways in which global health outcomes are often driven by kind of two key issues: one, law, the other, politics. And so you're going to hear me talk about those as the kind of driving pieces of the work that I do, but also I think of the pandemic. So here I'm going to go ahead and share my screen, so hopefully you all can see that well. The title of my talk today is Democracy, Capacity, and Justice in a Pandemic. And I'm going to walk through the brilliant folks that host the forum had asked me to kind of bring what is an international perspective on lessons from COVID-19. And so I'm going to talk about a number of different pieces. So here are 5 ideas that I want to put out there. And I'm not going to go too deep in any one of them, but I'm going to touch on them as we go. And those ideas are: 1, no, democracy is not bad for pandemic response. 2, the World Health Organization has often succeeded where others have failed. Three, the public health world mistook rich countries for well-prepared countries, and that there is much to learn from the global South for all of us. Four, that law is a critical tool for public health and pandemic response, and we need more work on that, but it definitely requires political analysis. And five, the justice in pandemic policies requires political analysis as well. So let me start with one. So on December 31st, 2019, China alerted the World Health Organization to an outbreak of COVID-19, which of course then was called an outbreak of a pneumonia of unknown cause in the city of Wuhan. The epidemic quickly spread as cases of this novel coronavirus were confirmed throughout China, and then quickly elsewhere in Asia, elsewhere in Europe, elsewhere in North America and Australia. On the 31st of December, right, the World Health Organization's office in the Democratic Republic, or in the People's Republic of China, picked up a media statement by the Wuhan Municipal Commission and brought that out into the world. Within 3 days of the confirmed human-to-human transmission, with cases rising and the largest mass travel event underway for the Lunar New Year in China, the Spring Festival, the Chinese government imposed what was an unprecedented, what's called a cordon sanitaire, where they shut down movement of 50 million people across Hubei province, was rapidly shut down movement. They curtailed transportation between cities, and they looked at all of the different ways in which that happened. The authorities effectively halted the Spring Festival in Beijing. They restricted movement into other major cities. 2 1,000-bed hospitals were built within days. These moves reflected a control that was only available in authoritarian governments. And the World Health Organization subsequently said they congratulated China as setting a new standard for pandemic response. And this caused worldwide, kind of, especially in the United States here, a bit of a crisis to say, does this mean that actually democracy is bad for public health, that democracy is bad for pandemic response? And this was a big, big question as things went forward. But if we actually look, one of the things we find is that we know that if we look at the earliest beginnings of the pandemic, right, the first known case is probably around December 1st. That was reported December 8th. And yet it was another 20 days before anything was reported up to the national government. And in fact, on the 30th of December, just before it was finally, the World Health Organization actually caught the alert that was happening in the media, the Chinese authorities actually warned 8 physicians not to be spreading rumors. That the public announcement happened, and instantly there was a shutdown of the market. There were all of these positive things. But as we look at that, we can kind of understand 3 key deficits that happened in an autocratic state. There wasn't the information available. So what we saw was the suppression of information in China that led to the outbreak in the first place. We saw that the incentives of politicians in the region were actually not to share the information out, but were to deal with it locally, which is the opposite of what you want in the middle of a pandemic. And that there was a lack of accountability because there was a lack of open media, there was a lack of opposition politicians, there was nobody there to push and say what was going on. And so what we've seen over and over again is actually a much more complicated picture. And I hope we can get into this a little bit about kind of what is the role of democracy. There's one narrative out there that says, wow, democracy is not very good for public health. But if we actually look broadly across the world, what we're increasingly seeing is that reductions in democracy are pretty bad for pandemic response. That if we actually look here in the United States, one of the things that's happened in the United States is that the US has actually been losing ground on every measure of democracy in the world. And that's worth noting, right? And that helps explain real challenges here at home. So I'm going to leave it there for a minute and just hope that we can come back to that question of how does democracy kind of play in? What we've seen worldwide is that actually democratic countries have been all over the map. Some have responded quite well, some have responded quite poorly, and that it's not been clear how to think about democracy in a pandemic. One topic, one idea. A second idea, the World Health Organization. So the WHO has been the kind of, I think, punching bag of the world a little bit. There's been a real push to kind of blame the World Health Organization for the pandemic including by our former president, right? Who, in looking for someone to blame, blamed the World Health Organization and blamed China, right? And it's just worth noting, right, that that this kind of narrative has sunk in a couple of different places. I don't know what you all are watching and seeing, but we're certainly, for those of us that work closely in global health, seeing over and over again a kind of almost bipartisan agreement that the World Health Organization has a problem or the WHO has failed. That there's another kind of strand that says, all of this conversation around the origins of COVID-19, suggesting that somehow there's been just kind of a massive cover-up. And what we need to understand is, what is the World Health Organization, right? So it's worth just noting the World Health Organization as a whole plays two really fundamental roles. One, it's a forum for political debate. It's literally a gathering of member states. There are members of the World Health Organization. They come, they govern the organization as a whole. The second is that it's a normative and technical agency. But let's understand what it really is. It's an organization with a budget approximately the size of a mid-sized hospital. It is probably smaller than the University of Chicago's hospital, than a variety of other hospital systems, right? It is a kind of small organization globally whose mission is to help global health writ large. So it's actually a relatively decapacitated organization, and we've seen that increasing over the time, over recent years, right? The World Health Organization declared a public health emergency of international concern on January 30th, right? And that meant that under the international health regulations, the World Health Organization was then charged with a number of things. But mostly what it was charged with was encouraging countries to share information with each other, right? The World International Health Organizations seem like they would be very powerful, and they are a legally enforceable and binding set of obligations between states. But what has proved true is that those have not done a very good job of actually compelling countries to do anything. What do I mean? So, for example, one of the things that the World Health Organization immediately said is they said, don't close your borders. That actually closing borders won't work. It won't keep the virus out. What it will do is it will shut down commerce. It'll do a variety of other things. Instead, do really good public health testing and tracing. Put that in place. Do things like, short-term quarantines for people coming in. Do those kinds of things. Meanwhile, at home, immediately, said the World Health Organization, you need to, every country in the world, start testing and tracing people with COVID-19. They helped create a test that was available worldwide to be produced, right? And what happened? Well, if we look kind of around the world, one of the things we saw, so here in the United States, what we saw was the opposite of that. The first thing the United States did was to shut down borders, and then imagined that shutting down international travel, specifically from China, was going to prevent transmission. Well, that's not how viruses work, right? And so from a variety of places, what was true is that the virus, by the time the order came, the virus was already in the United States, right? That people, you can't just say, let's only ban Chinese travel, right? And then, well, there's some more outbreak happening in the UK, we'll only ban UK travel, right? It's not the way international travel works. Meanwhile, we didn't set up a big, bold public health effort, but some countries did, right? So if you look, for example, the United States closed its borders, Canada didn't. Canada's come much better out of this pandemic than have we. South Korea, Thailand didn't close their borders, right? Instead, what they did is they set up huge, major testing and tracing campaigns. They said, we're going to do it at a massive level. We're going to invest millions and millions of dollars, each of them, into really robust nationwide systems to be able to track, trace, and test. And it worked, right? Now, these countries today are facing real challenges because it's the pandemic has gone on for a year and a half. But if you look at the death mortality in South Korea, they're struggling with 60, 80, 100 cases, while we struggle with 20,000. Okay, 3. Public health world mistook rich countries for well-prepared countries. So as we think about a kind of key idea, and this is the Forum for Justice in Health Policy, there is a huge reality behind the way in which we think about things that I would argue is neo-colonial, right? That is really a kind of idea based on the supremacy of wealthy countries that's deeply unwarranted. And it gave the United States a sense that we were the best prepared. In fact, here is the Global Health Security Index that was put out in The Economist magazine, right? And you can see, right? Where's the place you want to be? You want to be in the United States, Australia, France, the UK, Sweden, right? These are the places to be if you want to be well prepared for a pandemic. Well, we know that the United States has now been surpassed for the most deaths, but for most of the pandemic had the most deaths in the world. Australia has done quite well comparatively, not as well as New Zealand, but far better comparatively. The UK has been disastrous, right? And so clearly our understanding of what prepared looks like has been deeply problematic. And if you look here, you would think that the African continent was full of deeply unprepared countries. Here is just one example, right? So this is, and sorry for the hard to read graph, right? But what is this? This is the most prepared countries in the world. And as of October 2020, how many deaths did they have, and how many cases did they have? So some of the countries on the list did quite well, right? Australia did well, Thailand did well, Latvia did well, Malaysia did well, Singapore did well, right? Some of the countries that we thought were the best prepared did quite well, right? None of those are the richest countries in the absolute world, but some of them did well. But many of them did really poorly, right? So there's the United States, there's the UK, there's Sweden with the most deaths in the region. There's Brazil that did quite poorly. There's Chile that did quite poorly, even though we thought that they were going to be highly effective. So what does this tell us a little bit? One thing it tells us is that we don't understand what actually good capacity looks like, right? And one of the things to just note is that many of the countries in the global south did actually far better than countries in the global north, right? So I think of an example like South Korea. I think of an example like South Africa. I think of an example like Thailand and Senegal. What did they have going for them? Well, one thing they had going for them was community health workforce, right? There has been a huge investment by all of those countries in a community-based health system. It looks quite different. In South Korea, a lot of it is automated and it depends a lot on the use of smartphones, right? In South Africa, it is the HIV response, right? It is the community health workers that have been built there. In Thailand, there's been a huge effort to build community health workforce in the rural areas. This has been one of the critical differences. In the United States, we've really massively underinvested in anything like a community health workforce, which meant that testing, tracing, that was off the table. The second is recent experience, right? One of the things, and I don't know how you plan for this, right? But one of the things that it turns out is that South Korea came to a standstill under the SARS and the MERS outbreaks that happened a few years ago, right? South Africa has had the huge experience of HIV, right? And it used that mobilization to actually build the response. So for example, Slim Karim in South Africa has been the head of the task force on COVID-19. He's an AIDS doctor. He's been the leader in the AIDS response. And that experience is what let them be prepared. Now, South Africa has still been hugely hit and is right now being, I'll talk about this in a minute, but is being just really devastated in this new wave. But early on, they did quite well compared to middle-income countries around the world that were the centers of commerce in that same way. Thailand was the same. The fourth final to say is that also safety nets mattered a lot, right? And we've seen this around the world. Sorry, there's a crazy storm going on outside, and there are many sirens, and it's, I think, about to start storming. I have a feeling. So apologies if there's background noise. That as we think about the kind of the pieces there, the safety nets mattered. And so in South Korea, one of the things that they did was they built an ability that if you tested positive, you could very quickly move into quarantine, but you were supported. You got funding from the government to stay there. Your quarantine was actually made easy for you. We supported people to stay home. And then when they instituted small lockdown orders in parts, they paid people for their lost wages, right? It enabled people to actually decide to stay home instead of pushing them out into the workforce with COVID-19. All right, that's third one. Fourth one, law has turned out to be a critical tool in pandemic response. And so, what do I mean by that, right? And so we can think about a few different experiences around the world. Law, we don't often think of as a tool for pandemic response. And as we think about kind of what does it look like to be prepared and what is it, what are all the public health exigencies, we rarely talk about law as a piece of that. But what have we actually seen? So one, we've seen that you can compare, for example, a highly authoritarian response to less authoritarian ones. Now, if you're in China, that's a hugely effective response. But in most of the rest of the world, things that have been hugely authoritarian have actually triggered pushback. And so in Kenya, there was a big push to make everybody stay home, enforced by the police. And what it resulted in was far more deaths from police shooting Kenyans than from COVID-19. That was a huge problem, right? In South Africa, on the other hand, and here in your upper right-hand corner, this is President Ramaphosa of South Africa. He put in place a kind of a lockdown and a mandate, and it was largely quite effective. But one of the things that they did is they mobilized their community workforce to actually make it possible for people to stay home in many of the most impacted places. It was far from perfect. But for example, they had people delivering HIV medicines and food to all of the households in many of the informal settlements. Those kind of efforts made it possible for people to actually stay home and limit disease in the first set of outbreaks. In South Korea, a similar effort was made that really made it possible. Also, mask mandates worked, right? And inducements to stay home mattered a lot. So this is a paper that we co-authored with a bunch of colleagues from around the world. In the bottom left-hand corner, there's two different papers here. One is the rights that I'll talk about in a minute, but the bottom left is a paper where we actually looked at what happened when people stayed home and where the law incentivized people to stay home. And they did, which is not what happened in most of the United States, right? In much of the United States, mobility still stayed quite high in most places because you had many essential workers. And then you had lots of people running around, whether it was Uber or Uber Eats or various other things. Mobility actually did not decrease nearly as much. But the more mobility decreased, the more cases came down. And what you saw there was that incentives to help people be safe and well-fed and well-housed mattered a ton when it came to actually reducing those new cases. The other thing we saw is that human rights and pandemic response remain deeply linked. And this is back to the kind of very first thing that I said, which is, look, there is a huge idea that you can either respect people's rights or you can do good health, right? And this has become deeply confused, I think, in our moment here, where you've got anti-masking movements in the United States, and you've got people kind of decrying lockdowns and stay-at-home orders as if they are authoritarian measures. When in fact, one of the things that we've found is that there's a clear link between kind of doing human rights well and having good public health outcomes in the long term. What we have seen is that the United States is not alone in that where that people were not supported to kind of live through stay-at-home orders, that triggered backlash, right? Where there was overuse of policing, that triggered backlash, where there wasn't also supportive measures. And so it turns out that thinking about things like what enables people to stay home matters a lot if you look worldwide at where people succeeded. All right, a fifth point. Justice in a pandemic response requires political analysis. Well, that's like the least helpful probably sentence I've ever said, but let me try to explain what I mean. I'm going to talk about vaccines. So the pandemic has very clearly shifted to the global south. This is the most recent data. This is from yesterday, right? Which shows us that in the last 7 days, Indonesia has become by far the leading country in the world when it comes to confirmed deaths. Brazil behind, Russia, India, South Africa, Colombia, Burma, Mexico, and then eventually the United States. This used to look the other way around, right? The United States used to be at the very top, followed by the UK, followed by France, et cetera. Of course, the difference here is vaccination, right? Vaccines, it turns out, work, except if you don't actually give them to people, right? And so this has been a huge problem. This is today's picture of the countries. So on the left, you can see the countries that have succeeded, the countries that have coverage of the priority groups, which are older people and health workers, right? And so you can see in the high income countries, we've reached the edge of that. In fact, we've reached well past that, right? We're approaching, 60% in many high income countries, 70% coverage in many places. We have huge problems here in the United States, but we don't fall below 30%, right? I believe I was looking at this at one point. Mississippi, I believe, was the lowest coverage of vaccinations. And if you compared Mississippi, not a single country on the continent of Africa has the coverage that Mississippi has, which is our very worst state. Low-income countries, which you see in the kind of upper left-hand corner of this circle, have many of them not even covered 25% of their high priority people, right? And this is a deeply, deeply disturbing reality, right? You can see these two pictures. One is the New York Times headline, right? Let yourself enjoy this miracle summer. Well, it turns out that the miracle summer is not quite as miracle when the Delta variant comes about, but it's certainly not a miracle in Bogota, where you've got these folks carrying the coffin. The global South is seeing the kind of outcomes of the current pandemic. And so the question has to be, how did we get here, right? Why did we end up in this situation where there's so much vaccine in some places and such vaccine equity in other places? Well, it turns out that the answer to that question is not that nothing was intended to be done, right? But that there was an effort that kind of was mounted, but there were two different paradigms for how do we do vaccine equity. The goal was achieve vaccine equity. Well, that failed, right? We should just be very clear. We have not achieved vaccine equity. We have not achieved anything close to vaccine equity. But how come? So it turns out that there were two different paradigms that were used to think about what do we do about this. One was what I call the demand side law and policy paradigm, right? That said, look, we can do a bunch of advanced purchase agreements, right? Which means we're going to agree ahead of time. We're going to give some money to a centralized fund. That fund is going to purchase from the couple companies that exist, and the global South will get to have be on the same footing as the global North. They'll just bargain through this big mechanism, right? We're going to negotiate with companies making the vaccines, and then we're going to give these market-based incentives to scale up production, i.e. rich countries will subsidize poor countries. Billions of dollars was raised, and the idea was that they would buy vaccines with them. But as of today, less than 1% of all vaccines have gone into arms in low-income countries. Right? This just simply has not worked. Here is Ursula von der Leyen, the head of the European Union, right? And what she's talking about is kind of like, look, these funds will kickstart global cooperation, and they'll create a global public good. But it didn't work. How come, right? Well, the core is that there was another alternative to this, right? The other alternative to this was not pool a whole bunch of money, but was instead an alternative paradigm that said, look, pool knowledge, share knowledge. This has a number of different pieces to it, right? It includes the idea of saying, all right, Moderna, others, Pfizer, you all have created vaccines, but we're going to pool the know-how to do that, right? In many ways, these vaccines are a great opportunity for this, right? The United States paid $2.7 billion for 99% of the Moderna vaccine. Now, I love the other 1% of it came from Dolly Parton, right? So Dolly Parton gave $1 million. The United States government gave the $2.5 billion. And so look, it was a partnership for the Moderna vaccine with the National Institutes of Health. It was actually Dr. Barney Graham in the US National Institutes of Health who immediately after the Chinese scientists shared the genetic sequence, he tweaked it. He shared the kind of the thing that he had been working on in terms of a vaccine with Moderna, right? And Moderna went on to make the vaccine. The United States government paid for the trials, and it worked. So the question is, when that happens, who owns that knowledge? And our options are 1, try to buy a whole bunch of vaccines from Moderna. 2, share the know-how with the world about how to make those vaccines. And the one says everything will be voluntary. It's up to the state, the companies to decide what they're going to do. The other is the government says, look, we paid for this, we're going to share it with the world, and it actually uses law and policy to do so. Now look, both of these approaches might have worked, but if we actually think deeply about which was going to work, we have to think about ourselves, how's the world actually functioning right now, right? And the way it's actually functioning right now is that no country in the world that was a powerful high-income country agreed to share vaccines before their entire population got covered, right? And so there were many big high-profile events to say that vaccine sharing is going to happen. You saw that, the Ursula von der Leyen quote. All of that was happening. But in reality, what was happening was that all of the high-income countries were buying not one, but often 2, 3, up to 5 times as many doses as their populations would actually need, because they wanted to make sure that they had the first access. And the core that happened was that the high-income countries bought up all the supply. So while they said we're going to share, they said we're going to give millions of dollars to ensure that there will be vaccine access, in reality, what they were doing is they were buying up the whole supply. So now the COVAX initiative, which is the global effort to get vaccines to everybody that has been supported by the Gates Foundation and the World Health Organization and a couple of others, has ended up at the end of the line. And so it's not that they won't someday have vaccines, but they end up at the end of the line. The alternative to this would have been sharing the technology and saying, let's make the vaccines around the world. And in fact, in India, South Africa, Senegal, Thailand, Brazil, there are factories that know how to make vaccines. Huge global companies that actually produce vaccines in the global South, that produce all sorts of generic medicines, including those used here in the United States, and yet we didn't actually make use of those right now. So I'll just end by saying we're beginning to see a paradigm shift here, I hope, right? So just the other day, there was an announcement that in South Africa, that they're going to create what's called an mRNA vaccine hub, right? The South is finished waiting for donations from the global North. It's become clear that that's not going to happen, right? That those are never going to be enough, right? We're seeing millions of doses donated, but the need is 11 billion doses worldwide. And so what they're doing in South Africa is they're creating a vaccine mRNA hub. They're bringing in many of the scientists around the world who know how to make mRNA vaccines, which are the Moderna vaccine and the Pfizer vaccine. And they're saying, look, we're going to actually actively compete. We're going to try to reverse engineer. We're going to try to figure out how to make our own. But please, Moderna, Pfizer, please do share your technologies at the time at which you can. But we can't afford to wait until you're willing to sell us doses. Literally, they have money in hand and they cannot buy doses around the world, because what's happening instead is that we're thinking about whether we need booster doses in the global North. We're beginning to maybe see a shift. This is Gail Smith on the bottom left, who's the US envoy on COVID-19 here in Washington, D.C. at the US State Department. And she finally, after quite some time, has come out and said, look, we do support a kind of, an intellectual property waiver that would waive the intellectual property on vaccines around the world, which has been stalled. I'm happy to talk more about that, been stalled in the World Trade Organization. And we also support pushing these companies to do so. And it's just worth noting that the United States has the legal power to do a lot here. It turns out that the United States can use the Defense Production Act to do more, but also the United States co-owns part of the Moderna vaccine. It actually has a patent itself on the Moderna vaccine. And so the United States government could exercise its authority to actually ensure that those pieces happen. So in summary, what we need to be seeing here is more role of the state, more role of law, a more active engagement, a kind of worldwide, in both regulating behavior, but also ensuring equity. That where the state has acted boldly, where we've seen governments act boldly in the interests of their citizens, we've seen effective pandemic responses as possible, even in the face of a Delta variant. But where we haven't, where we've seen the retreat of the state, it's been much harder. And that's where we are today. I'll end there and look forward to discussion, Dr. Murray.
Well, thank you so much for a great summary, Dr. Kavanaugh. I think you've given us a good outline around which to frame our conversation and discussion. Let me just for the sake of our listeners, and you can start asking questions whenever, we'll insert them as we can. Let me go back to something that you mentioned about I forgot what the exact word is, but the exact name of the report. This report that attempted to categorize who was well prepared and who was not well prepared. And I'd like us to talk a little bit more. You talked about some of the lessons from the global South. Let me just say, when that report first came out, which was before COVID-19 was public, I can't remember how much. I don't know if I can remember, my dates get after quarantine. I can't keep track of any time frames.
It was months. It was actually amazing. It was a few months before. Yeah,
the fall of 2019, I think
it was.
So as a public health person, this crosses some email or something, and I'm looking and it says, global pandemic readiness. So in public health, especially governmental public health, we have been, quote, writing global pandemic plans for most of my career. Okay, so even though this may have been a surprise to the general public, it wasn't a surprise to public health people. So I remember looking at that report, and they said it's bad enough that they said that the rich countries were the most prepared. That part didn't surprise me so much. But when they said the United States was the most prepared in the country, I said, oh, there's something wrong with this report. So if you think about some of the issues, I guess what I'm trying to ask is, how would you frame a report card, a checklist around which countries around the world should say, are we prepared or not? What do you think should be in that kind of metric?
So it's a great set of questions that we are grappling with right now, and I totally agree. Right, I remember seeing that, and I know the wonderful people who put it together, and I don't mean to knock on it too much, right? But I will, right? And I knock on it to them too, right? Really great people at Hopkins and a couple other places. But look, right? Nobody in my world, which admittedly is a progressive global public health world, thinks that the United States is the most prepared country for a pandemic in the world. How do we know that? Because of how we've responded to pandemics that have come before. Let's look, right? Let's look at HIV. A lot of my career has been spent on HIV. There's no argument that the United States had the best response to the HIV in the world. There's no way, right? The United States' response to HIV was deeply problematic. And so we can ask ourselves, how come? And so my answer to your question is kind of twofold. On the one hand, there are a number of capacities that I think we need to think about, right? This kind of some of what I had talked about in the talk about, like, look, we need community health workers and a community health workforce that's actually mobilized and able to do so. We need civil society organizations that are strong and vibrant and well-funded, that are able to do the contact tracing and are trusted in communities, right? They need to be available and strong. We need to not see the retreat of public health infrastructure that's actually well-funded at the local level, right? And so, as you say, anybody that does local public health has to laugh at the idea that what exists in the United States is massive capacity to respond to a pandemic. Well, obviously that's not true, but anybody that works in a health department knows that the capacity has been, eaten away over decades. But the other way to think about it, I think, is really to think about some political capacity. And we've been talking a lot in our world about, like, what does political capacity look like? Because the roots of some of these problems lie in structural realities of society that haven't been overcome, right? It turns out, and we're doing some look at this, but I think racism is deeply tied to how you respond to a pandemic, right? And I think we're seeing that the deeper the ethnic cleavages worldwide, the harder countries have had responding to the pandemic, right? And so the United States' reality, why didn't we respond well to HIV, was deeply embedded in race, but also deeply embedded in our understanding of sexuality and the marginalization of Haitian folks and all of that stuff. Well, that same reality has come to the fore here, where we say there's some people's lives are more valuable than other people's lives. Just a random fact, but in Singapore, right, you saw an incredibly effective response right up until the point at which migrant workers had COVID. And when that happened, all of a sudden there was an outbreak because nobody was paying attention to the migrant workers because they were marginalized in society, they were pushed aside, and they were economically unimportant. And so no one even noticed in the surveillance because no one was paying attention. Well, that's the same thing that we're happening. So I think we have to think kind of broadly about that. And then the second is it's great to have good capacity writ large, but if you've got political leadership that doesn't believe in science and doesn't trust science, it's hard to actually mobilize that. So we're doing a little bit of measuring of, like, how do governments actually, function, and what would it look like to have a good pandemic prepared government? But it's got to be somebody led by somebody that believes in science. So I don't know how we quite fix that one, but.
So Wesley is whispering in my phone that people are asking a little bit more information on that particular report. I'll try to hunt it up. Global something assessment.
I will. I'll put it in the chat.
Very good. They had a series of criteria. Personally, I was critical even of some of the criteria that they picked. But the main thing is there's a big difference between making a decision. For example, the CDC. Actually, I think this is true much of the time. The CDCR, the United States CDC, is the premier public health agency in the world. Let's pretend that's true. That's fine. But if you don't understand that we don't have a national public health system in the United States, by our Constitution, health is a state level responsibility. So in fact, the CDC and frankly, even the federal government in terms of actual public health mandates has no authority. It rests with all the states. So we actually have 51 or 52, however you want to count it, different state public health agencies. So if you don't catch that, the fact that CDC may have the best labs for something is sort of irrelevant. So he put it in the chat so people are free to go look at that. I don't think it's a bad exercise, and I do agree with him that those were good, solid public health colleagues that put it together. But let me suggest this. I saw it mostly as a difference between, and I don't mean to insult academics, but between a sort of academic view of preparedness and an on-the-ground clinical view of preparedness. You had so many great things for us to talk about. One thing that I wanted to mention early before we go into some other questions in the Q&A box is that one thing that you mentioned, which I think is really important, and I wanted to talk about it early, is that your institute felt that human rights is linked to pandemic response. And so in the context of an American conversation where people think of human rights as sort of the 2-year-old version, you can't tell me what to do. You're not the boss of me. That's what my 2-year-old always told me. That in the world notion about human rights are linked together. So you can't have the right to move where you want to without the right to also have healthcare and food, clothing, and shelter, and be free from stigma. So all these rights are linked together. And so what we have to ask ourselves as Americans are, if you don't have a right to eat, okay, you don't have a right to a house, you have to actually pay rent, which is what we do in the United States. When we say we pay people that are unhoused, what we're saying is you cannot occupy space legally in most of our country, certainly in the city of Chicago and without paying rent. Because if you just are sitting on the street, the police are going to come and arrest you. So think about what that means. You have to pay rent to occupy space in our country. How does that lack of basic rights, how does that go map onto an ability to respond to a pandemic? We're talking about COVID, we mentioned HIV, but there are other little small epidemics we have all the time amongst people who are unhoused, and we sort of ignore. So I thought that point of linking human rights in all of its complexity to a pandemic response is critical. And I would just wonder if you think, ignoring for just a brief moment, some of the styling of government, authoritarian, etc., how do you think the notion of honoring human rights tracks to pandemic response around the world?
No, I think you're entirely right. I mean, I think there are a few different pieces in what you're saying here, right? So one is just to break down that in most of the world, right, there's a kind of broad recognition of multiple different levels of rights, right? There are the political rights and freedoms, and then there are the socioeconomic rights, right? And so in most of the world, those go hand in hand. And so you look at a place like South Africa, or you look at actually 50, I know you used to know the answer to this, 53% of the world, I think it is, right, has a constitutional right to health. But the United States has this very strange approach to rights, right? We recognize political rights, right? We recognize kind of freedoms from, right? So the government may not impose upon your speech, right? And we recognize that without recognizing the positive obligations of government too, right? And this is a very strange neoliberal kind of libertarian understanding of rights to most of the world, right? I mean, I talk to colleagues around the world who work on kind of human rights perspectives perspectives, and they're astounded, right? The United States is one of the few countries in the world that hasn't signed a covenant on social and economic rights. And in there is embedded, right, the right to food, the right to housing, the right to health, which places an obligation on the state to progressively realize that obligation and therefore balances things out. And so we end up in a situation, right, where the only conversation in the United States about rights is, can you infringe on my ability to move from here to there? Right? And if that's our only understanding of rights, then when the government infringes on your right to move from here to there, then it's somehow a violation of rights. But if we put that in a bigger perspective and we say to ourselves, well, is your moving from here to there going to spread a disease? That's not so good. If we're going to impose a limitation on your right to move from here to there, what obligation does the government then have? Does it have the obligation to provide food, to provide shelter, to ensure that you have good medical care? It has played out really clearly in this pandemic, where when people in the United States came tested positive for COVID, the choice of whether to go back to work was often less about whether or not you were positive for COVID than it was about whether or not you needed the money to work, right? And so that was not true in South Korea. In South Korea, if you tested positive for COVID, you were actually treated incredibly well, right? There was an easy place for you to go to quarantine. It was on the government's dime, right? Nobody was told, go home, and I hope you don't have a multi-generational family, and I hope everybody has like a great giant house where you can just go like have a section of your house that you can cordon off to not work and to go be quarantined, right? In countries that didn't do it that way, that really supported people to be quarantined, they were able to do that quite effectively. The other thing is, when government imposed things like, obligations that you have to test, and if you do test, you have to quarantine, in some places that was enforced by the police and it was very intense and it was just a negative, right? It was you're gonna get in trouble, the police will come. The other alternative to that was helping people live well, right? And in the places where they helped people live well, you saw people coming forward. They weren't afraid to test positive. They wanted to be able to quarantine well, right? And so that mattered a ton. But then the other thing is, where you saw state violence against people, where people don't trust the police, that in and of itself was a violation of human rights. And that led to people not trusting the public health authorities and not actually coming forward with COVID cases, right? And so I think all of that played together. So there's a kind of deep and abiding connection between doing good public health and doing good human rights. And when you do the two together, that's where you see success. If we just say, public health overrides everything else, we don't do very well, right? But if we say human rights are just this very narrow piece, we didn't see that do very well either. And the examples of this are rife, whether or not we're talking about the United States or Brazil right now, where the response has not been in Brazil a positive, supportive socioeconomic response. It's been the opposite. It's been much more of a US Trumpian kind of response, right? And we've seen real damage. The UK, same deal. So I do think that plays a huge role in whether or not we're supporting people forward. And I think that it plays out empirically, right? Those are the countries that have actually done the worst in the COVID pandemic.
And I think that's a great metric to use. We have a couple of questions in here that center around vaccines. So let me just read a couple of them and try to frame them and see your response. So there's one question about mandating vaccines in the world, which it's an interesting thought for Americans, but that's okay. And especially for people that don't have access to vaccines, this person is saying. And then there was another one. Oh, what about voluntary initiatives in terms of knowledge sharing, which was one of your approaches to vaccine equity? Let me raise this and see what you think about this. One question I think that's even more fundamental than those two, which is, how is the knowledge generated? So I know when I've been working with communities in Chicago and around the country, some people were very hesitant because they felt that the vaccines were developed, quote unquote, too fast, when in fact these vaccines took decades to develop. And frankly, certainly with the mRNA vaccines, the newer technology, these vaccines have the basic science on which these vaccines rest depended on governmental money from around the world, not just the United States, but European and Japan too. So you have public taxpayers, for lack of a better word, a common effort to generate the knowledge on which these vaccines rest. And so one has to ask the question, Moderna is an excellent point, of course, since we governmentally co-own that. But ignoring that reality, what does it mean to say that the knowledge that's been generated with these vaccines should be kept by a small handful of multinational corporations? Is that really not only is it fair and equitable, but is it reality? Did they really produce that knowledge by themselves? And then if not, how should we then think about vaccine equity?
Yeah, no, I think that it's another great framework. I think so. Look, exactly as you're saying, let's go back a second, right? Let's just take the kind of the mRNA vaccines. Where did they come from? Well, a lot of the work for mRNA vaccines was done at the University of Pennsylvania, right? It was the University of Pennsylvania funded by the National Institutes of Health. And it was somebody named Katie Keriko who went off and then founded was joined BioNTech a little while ago, right? But she was the one who did a ton of the work on making mRNA work, right? It was her and a couple other people at the University of Pennsylvania, supported by government grants, to learn and to understand how mRNA worked. And then once we understood how mRNA worked, then to turn that into something that might have public health impact, right? And then from there to turn it into vaccines. And then late in that process, at some point it went to be commercialized, right? So Moderna went off to commercialize the one that was created by the NIH, building off of all this technology. In Europe, the Pfizer vaccine comes from BioNTech, right? And so BioNTech was this entity founded by this researcher, or not founded, but joined by this researcher from the University of Pennsylvania, who after years of being supported on a variety of grants and struggling and being a kind of amazing person, went off and joined this company that finally gave her the support to develop this. But do you know where BioNTech got its money? It got it from the European Investment Bank, right? This is public sector money that supported BioNTech. So that they then sold the rights to Pfizer. But Pfizer didn't do anything, right? Pfizer bought the rights to it and commercialized it, right? And look, there's value in that, but does that value mean that we need a global monopoly on the ownership of the knowledge? And this is where we are in, I think, the worst timeline, right? We're just in this very strange idea that what you need to incentivize innovation is ownership of and monopoly over the knowledge itself, right? So we've given it to Pfizer and we've said, you're the only one that can do that one. We've given it to Moderna and said, you're the only one that can do that one. AstraZeneca, same deal, right? You're the only one that can own and control this globally, even though that was supported by the UK government and the European governments, right? Johnson & Johnson got huge amounts of money from the United States. So this is kind of common knowledge that we've paid for. And we don't have to accept the idea that what's going to incentivize innovation is global monopolies, right? So on two fronts. One, that's not why these scientists did it. Let's just be really honest, right? And the mRNA vaccines are a great example of this. Katie Keriko, I urge everybody out there to go read the story of her. There's some podcasts of her. She's a super interesting and compelling figure. She worked for $60,000 for most of her career at the University of Pennsylvania because she was so interested in the work. She didn't innovate so that she could have a global monopoly. She innovated for years, like literally photocopying her own thing because she couldn't get a staff, right? Scientists aren't driven by this kind of the monopoly idea. And so this idea that we need that for innovation is bunk. The idea that we got COVID vaccines because of intellectual property is also bunk. We paid billions of dollars. The idea that somehow companies are going to say, no, we don't want $2.7 billion to innovate. Nobody's going to turn that down. That's just not a reality, right? And then we can ask, do we need patents in the United States? And do the patents in the United States need to look exactly like the patents everywhere in the world? And this is the fight that's going on right now at the World Trade Organization, where South Africa and India have proposed a waiver on intellectual property related to COVID-19. And that means patents, but it also means trade secrets. And trade secrets matter because, for example, if you could hire Katie Keriko away from BioNTech and bring her to South Africa, she would not be allowed to make her vaccine for a company in South Africa because of trade secrets, right? And so we need to kind of take the whole intellectual property thing and say, look, this maybe it incentivizes certain kinds of innovation. Right? I have an interest in like male pattern baldness drugs, right? So maybe we can figure out how to do some of those better. But maybe we can also accept that those drugs are not the same thing as a vaccine in a pandemic, right? And we can say, look, let's suspend the patent obligations for now, which doesn't mean the patents in the United States go away. it means that every country around the world gets to decide whether or not they want to have patents on vaccines. And so if we feel like it's working really well in the United States, fine. I'm not sure it is. I don't think it is, actually. But we could even say fine, but does it have to be the same in South Africa, the same in India, the same in these countries that, frankly, the high-income country-based companies are refusing to sell the vaccine to? The answer is no, we don't have to do that. And what we need to do is we need kind of three different steps. One, we need to waive the patents. We need to waive the intellectual property writ large. Two, we need to compel the sharing of technology. And so somebody had asked about the kind of voluntary, the CTAP measure, which is the Coronavirus Technology Access Pool. What was that? That was the World Health Organization and the Costa Rican government getting together and saying, all right, companies around the world, please voluntarily share your technology with us. We will match you with a factory around the world so that we can make the most vaccine humanly possible. Crickets. Nobody volunteered, right? And this just tells us that, hey, we have government for a reason. We need the government to act here. So government has a lot of opportunities. I had mentioned, right, the Defense Production Act we've seen talked about a bunch, right? The Biden administration could tomorrow invoke that and use that to say we're going to share the vaccine technology with the world. The Biden administration has a variety of other mechanisms as well, the European governments as well, right? So I think we need to think about the ways to get this technology and force it to be shared with people around the world, because, by the way, that helps us. Why do we have the Delta variant and why is it spreading so much? In part because we didn't have vaccines fast enough. What's the next variant that's coming? Is it worse than the Delta variant? It might be. But how do we stop it? We get everybody vaccinated. And so it's deeply in our interest to ensure that that happens. And right now we are, I was saying this recently, like there's an idea that like vaccines work, vaccines stop death. But the evidence right now is that vaccines don't do that globally, right? Currently, that deaths are stable, right? If we look across the world. And that's because there's a lot of folks. I am able to work from my home, right? In Washington, D.C., I'm at relatively low risk and I've gotten my vaccine, right? So yes, that was the right thing to do. But should I have gotten the vaccine before the grandmother in South Africa or before the Brazilian health worker? I don't think so. I don't think that actually makes sense. But that is the way it's happened because we've given a small handful of companies, they're the ones deciding which country gets how much of which vaccine at any given moment. I know a long answer, but I'll just wrap up by saying, like, we just need to be very clear that that's what's happening. Is that right now, despite all of the conversations about ethical allocation and the World Health Organization's role and all of these international mechanisms, the allocation of vaccines, which country gets which vaccine in what quantity, is made by a handful, 5, 6 companies, and the government the officials in those companies, not by public health authorities. And that is an abdication of global norms, and we need to get public health back in there so that the allocation decisions make sense.
And I might add, in contradiction to the global public health plans for these pandemics, here's a great question from Mia. As a public health practitioner and advocate, I want to wholeheartedly agree that what we need are more civil society and public health community-based organizations. But so much of pandemic response was defined by small, effective actions early on. Taiwan, as an example, comes to mind as a positive example. As we often say, when public health works, nothing happens. Maybe beyond political capacity, we can also think about the government's administrative and institutional capacities. Did these capacities historically exist in the US? Where might these capacities come from here and now?
What an interesting question. I love this. This is really interesting. So I, I'm not an expert in the history of U.S. public health, and so I'll leave that to others probably on this call and others who really are. But I think your point is exactly right? That these core ideas of administrative capacity and the ability of government to do things is really fundamental and central. And what you saw in effective responses worldwide was a couple of different pieces. One, you saw early action. And so when I say political capacity, I kind of mean, did the government take it seriously? So in South Korea, the President Moon Jae-in immediately acted upon the World Health Organization's recommendations, took them up, put it into place, and made it happen, right? That was a critical decision that was made really early on. To your point, Taiwan did something very similar. Thailand did something very similar. In the United States, we did exactly the opposite of that, right? We said, we don't need to do what the World Health Organization is saying. We don't need to implement good public health. We'll just close the border and we'll hope that that works. That has turned out to not be a good choice. But then to your point, even if what we had done was to turn, and I feel like, Dr. Murray, you've been saying this several times, right? Like this idea that we could have turned and said, if the Trump administration had somehow been sane at the time and instead said, we want to mobilize every resource we have, we still would have found that our resources came up short. Right. And so this idea of public health, giving it more resources, giving it more capacities, and being really clear on what a frontline health system really looks like worldwide is really important. Internationally, if you look at low and middle income countries, much of my work is with colleagues, brilliant folks in East and Southern Africa, some folks in Southeast Asia, and the work that they do on infectious disease response is deeply dependent on these frontline health capacities. And you can measure them, you can figure out who they are. And I always say, if you can't tell me the people who are going to be in charge of that when it happens, then there aren't any people, right? And that piece matters. And so as we think about what we should invest in, some people are like, okay, we need to invest in massive, brilliant new labs to detect things. And sure, let's do that, right? But we also need massive investment in these frontline capacities. And one of the things that has happened, I think, if we see worldwide, the reason why South Korea has remarkable frontline capacity is because they lived through SARS. They learned the lesson from that, and their response was to actually institute that. That is the opportunity we have in the United States, right? You really could see that. Now, we have the problem of federalism that you brought up, right? Which is we don't have one public health system. And federalism has turned out to be a really bad plan for pandemic response. Countries with federalism have really struggled, but they've struggled differentially. In Germany, it's a deeply federal place, right? But they've still been able to mobilize a national response because they put that in place. So my sense is, that even if Angela Merkel were not a remarkable leader in many ways, you still would have seen a remarkable public health response in Germany because of the capacities that they've invested in. But even there, we've struggled. So I think this is the question for the United States. Are we going to spend the next 5 years investing in and building those frontline capacities? Or are we going to try to somehow imagine that we can do it all with like the internet? And like with this, next time it'll be different because Joe Biden is president, which I think is a real threat, right? I'm a political scientist at heart, right? This is our real threat is we think everything's fine now because we've changed administrations. And that was not the heart of our biggest problem. No.
I agree with you. We cannot blame our pandemic response on Donald Trump. He didn't help, but he's not the fundamental cause. This question of administrative capacity, I want to encourage us to think not just about public health and our medical capacity, which are challenged, but even if you remember the basic process of trying to get people the extra money on their unemployment checks varied so much across the country. And many, many states, including ours, had a whole bunch of hiccups because they had ancient computer systems and they couldn't figure out a way to go in and make these relatively minor changes. So the notion that government, what we do collectively, is somehow unimportant or worse, as many Americans think the problem, means that we've gutted all of that infrastructure. So it's not that we lack administrative infrastructure in the abstract, it's just that we have not placed it where it needs to be in government. And it's really hard to try to go back and do all of that just because you have a little bit of money now. We have a question.
No, totally. And I mean, just to say briefly, the idea of neoliberalism, right, has deeply seeped into the world in various places, right? This idea that government governs best, that governs least, right? The Ronald Reagan, the worst thing possible is I'm from the government, I'm here to help, that's a problem, right? That has deeply undermined our ability to respond to pandemics. And you can actually look around the world and you can see this happen, right? The UK and the US were the centers of the neoliberal paradigm, right? This was the Margaret Thatcher, Ronald Reagan move. And you can see this throughout where we've done. done. And the move there was to disable the state. As somebody that studies political science, disable the state, meaning the capacity of government to be able to respond to things. And we are reaping the rewards of that right now. The United States and the UK have led the world in the worst COVID responses. And yes, there's been a kind of populist political response at the very top, but I think you're entirely right that it's that kind of hollowing out of the state capacity to do anything that I think we have to really rethink. And I see the current US administration as starting to rethink that. I think some of the conversations around infrastructure and various other pieces are beginning to recognize that actually we've gone in deeply the wrong direction in that sense. But countries around the world that didn't do that didn't take a neoliberal turn, have actually seen much better responses. Several of the Scandinavian countries have seen that, but so too have some of the countries in the global south that have really invested in that and refused a neoliberal paradigm. So I think that that's critical. Yeah.
And we have a question that goes into a little more detail about that, asking about what models should we look at from around the world that about community health workforce in terms of raising their visibility and importance.
I had mentioned Thailand early on, but I think that they're one of the really remarkable examples. Thailand is a country that has a kind of very interesting long history of support for public health, and it's deeply embedded in the kind of the politics of the country. And they have instituted a universal healthcare system, right? That is pretty remarkable, and for a middle income country, a lower middle income country, they've rolled out community health workers in various ways that are really quite impressive. Ethiopia has also done a really remarkable job in this, right? Where, and unfortunately, everything that's happening in Ethiopia right now is really undermining that. And we've got a kind of huge problem politically when it comes to the massacre that's happening, in Tigray. But the realities of the health workforce and the frontline community health workers in Ethiopia have actually been remarkable. There's a reason that Dr. Tedros, the head of the World Health Organization, comes from Ethiopia, right? They have figured out how to build with very low resources, community health workforce that is remarkably well trained, that does a lot of that. The third is to say Cuba, right? So, as we think about and again, politically charged realities, the Cuban health system has invested massively in block by block capacities that have put the United States maternal mortality rates to shame. And they've done that largely through community health workers. So I think those three examples are three good ones. And it really, to me, is in part about how does the United States humble itself? How does the rich world humble itself and say, wow, it is really notable that a lot of countries with 1/100th of our GDP have responded far better to COVID-19 than have we? What lessons can we learn? Can we actually learn those from the South instead of the kind of model of global health that we've often had, which is the United States knows and it will teach the world? I think this is a moment for us to step back and say, what can we learn from low-income countries that have figured out how to do things that we haven't been able to do?
So we have other people fussing at us because we have not directly addressed mandating vaccines. I know the original question was about global mandates, but we can also talk about national mandates and other kinds of mandates. So what's your thinking on that?
Yeah, so let me say a couple of things on this. So one is, when I read, and hi Jim, nice to see you, or virtually, when I first read this, the thing that I thought about at first was the global vaccine mandate that we currently have is that you increasingly cannot travel unless you've been vaccinated, right? So if you're trying to go to Europe, you're trying to come to the United States, you're trying to go to any of those places, you can't do it unless you have been vaccinated, right? You're not allowed into the country. And that is deeply unjust, because at the same time as we're imposing these vaccine mandates, we are withholding the vaccines from the people. And this matters not just because it's theoretically unjust, but because it's deeply economically unjust. Actually, the global economy is so deeply intertwined in 2021 that to do business, to be economically viable, you need to have your citizens traveling the world, being engaged in it. And so we're cutting off entire sections of the world. The International Monetary Fund just yesterday put out an updated growth rate, and it slashed the growth rate expectations for low and middle income countries, and it increased the growth expectations for high income countries, right? And this is straight up economic inequality between countries that is 100% driven by vaccination rates. So in that sense, I think we're doing a really bad job globally, and it's deeply unjust. go to the other side of things, which is, I think vaccine mandates in the United States and other places make a ton of sense, right? And I think, kind of, I'll put on my like based at a law school but not a lawyer hat, and say that the U.S. Constitution absolutely gives states the authority to do this. It also gives businesses the authority to do this. We should be leaning into that authority as much as is possible, to ensure that people are required to get vaccinated in all of the different legal ways that are required, because, and there is just a ton of good evidence on this, there are many reasons why people don't get vaccinated, but very few of them are about personal health realities. So where the personal health realities are a piece, that's obviously a minority. But what we know is that there are lots of good reasons why people don't get vaccinated, whether that's because of, internal beliefs, or whether that's because they are busy, they are scared, they have all sorts of things going on. And so the government has a role to push it. And there's a kind of really interesting kind of literature in economics that's about nudges, right? That's about like, what are the ways in which we nudge people toward the right behavior? And mandates are all about that. I have a good friend who said this the other day. She is an epidemiologist. She did not get her kid vaccinated because he really hates vaccines. He freaks out, like people have to hold him down to get vaccinated. It's this very intense thing. Like he freaks out. And so she skipped some vaccines for him, which she's an epidemiologist. It's like, oh my God, how can you have done that? And she was deeply embarrassed. She skipped it right up until the nurse called and said, you can't send your child to school until you get that done. You know what she did? She got it done immediately. Because it wasn't that she was against the vaccines, but there were all sorts of things that get in the way. And so I do think that we need to think deeply about the role of the state in doing that. And it's not just about a kind of jackbooted imposition of an idea, but it is instead also about kind of enabling people and supporting people to make the choices that are right. And I don't see how we get out of this pandemic unless there are many more mandates. So I've been really thrilled to see the companies that are actually moving on this and requiring it. I do wish that we weren't just putting it down to companies, but other countries, by the way, it should be just said, are instituting, and I know this is like a bad word in the United States, vaccine passports, right? And here's Joe Biden. There will be no vaccine passports in the United States. Vaccine passports are, they're called your vaccine card, right? It's like, it's not that deep, right? And it gets you into places like school. Well, other countries are actually increasingly innovating in this, right, and making spaces, and so you can kind of make virtual ways in which you can have vaccines, so that you can go into coffee shops and do those kinds of things. And those kinds of nudges mean that you're increasingly unable to kind of do many things that you like unless you're vaccinated. And I think that's actually a very positive way to think about the world in a context in which maybe there are people who don't want to get vaccinated. No.
And this brings us back to some other questions that have come up, but back to what you talked about earlier, the role of democracy. What's the role of democracy in addressing a threat like a pandemic? How do we do that? How do we figure out what the response ought to be and what's the correct response? So we've had a question to asking us about Chicago level violence here in Chicago. They mean person-to-person level interpersonal violence, and also raising a question about one of our big, they tell me this is music. I'm going to be crude here. I'm old, so I'm not clear that it's music, but Lollapalooza out here as a big concert with 100,000 people a day.
Yes.
How are those activities? How do we place those issues in the context of both democracy and rights in terms of how we address not only this pandemic, but many other pandemics?
To me, I will just say from the beginning that I don't know what to do about kind of, interpersonal violence in Chicago, nor do I know what to do with interpersonal violence in Washington, D.C., right down the road from me, where we're seeing rising violence. And I think, there's a kind of a wide variety of folks who are far more expert than I am to comment on such things. But what I'll say is as follows, right? That one, we have this kind of a very strange understanding, I think, increasingly in the United States about what democracy is, right? And it's democracy is a kind of very narrow version of it that it involves elections and involves the recognition of personal freedoms to do, right? And so it's somehow democratic to be able to hold Lollapalooza, right? And that's a really different understanding of democracy than I think most scholars of democracy would say, right? I think there's a lot of understandings of democracy that are much richer. And so one of the things that we've been looking at actually is, do countries that are seeing declining democracy versus countries that are seeing expanding democracy, is that actually a factor in their pandemic response? And so I say this, for example, where in the United States, I mentioned this, that we really are seeing seeing declining democracy. The well-being of our democratic institutions is really under threat, and that is kind of globally from scholars that look at that unquestionable, right? That I think plays a role in whether or not we're able to respond, because are we able to make decisions together? On the other hand, countries that are seeing rising democracy, where that's kind of growing, I mentioned South Korea several times. South Korea does not come out of a long democratic history. It's a relatively recent democratic history. And that democratic history has been growing, and the kind of presidents have been more accountable. Those accountability mechanisms in which we can make decisions together about things have actually enabled, I think, much better policy. And so, I think that there are ways that we can collectively decide not to hold giant, scary music festivals when they don't make sense, without that being somehow a threat to democracy, because I should be able to infect whoever I want to. But I do think that goes deeply to how do we understand democracy, and what is it that we're working on? Yeah.
So this brings me back to now. I'm going to say here that I'm also not a lawyer. So let us talk about the law for a moment. You and I, two ignorant people together here.
Excellent. Sounds like a plan.
So one of the fundamental issues in public health in the United States and globally, but certainly in the United States, is the notion that public health has police authority. What do I mean now? I don't mean Chicago cops police authority. I mean legalistic type police authority. What does that mean in English? That means there's an assumption that I make in a democratic country that if I send my 7-year-old to school, the school cafeteria is not going to feed them poison during lunchtime. Or that if I go to a store and buy milk, my kid's not going to drop dead because that milk makes them sick. Or if I go to a movie theater or Lollapalooza, the government is not going to allow a novel virus to run rampant through the population and kill my child. So police, now another way to think about police authority is, if our country is invaded, which hasn't happened, but anyway, if our country is invaded by another military, the country will use its police authority, its common authority to repel that invasion. So I guess I am certainly concerned as a public health person. I don't know what my lawyer friends think. I'm really concerned about the strength of our traditional legal police authority in the United States. And I believe that it is under attack, not just by crazy people. I believe it is under attack across the country. And if those attacks become more successful, how will it impact our ability to respond to pandemics?
I think you're entirely right. And I will put on my based the law school, pretend to be a lawyer on television, but definitely not a lawyer in reality hat. To say, right, this goes back to one of the fundamental rulings by the United States Supreme Court, which is the Jacobson case, right? That argued that was all about vaccination, that said, yes, the state can compel vaccination. And yes, that is within the police authority of the state, because the state governments, and here I mean it not in the broad state sense, but in the the states like Illinois have the authority to enforce behavior in public, enforce what we do with our personhood in a way that the federal government does not. And I think it is very dangerous what's happening at the Supreme Court right now. We're seeing these rulings come down, several California cases that have come down recently, right? Overturning, and we're seeing this in some of the state courts and some of the other federal courts, overturning the state's ability to enforce certain laws. Most recently, these Supreme Court cases have hinged on religious liberty, right? Can you tell churches that they can't hold services, without masks or without vaccination or whatever? And the Supreme Court said no, right? Basically, increasingly. And I think that is eating away at the legal authority of the government of states in ways that's really damaging. And I do think we are on a little bit of a knife's edge here, where, we could go toward a world where essentially, you can't tell me to do anything, right? Government can't tell me no, right? Which puts us in this very libertarian kind of understanding of the world, in which we are each out for our own selves. And, I think I have huge respect for the CDC director, Dr. Walensky. She is a remarkable person, and I think a brilliant AIDS doctor, and I've actually known her for many years. She is brilliant, but she has several times said this idea, like, your health is in your hands, which implies that the state doesn't have a critical role in actually enforcing core health mandates for the greater good. And I think that's hugely dangerous. And I think where there's a happy medium somewhere between an authoritarian state and a state without the power to act. And, I make this analogy sometimes that, I do a bunch of work in Haiti with colleagues there who are brilliant, amazing leaders in Haiti that are really struggling right now with a state that has no power to act, that doesn't have the ability to curb violence, that doesn't have the ability to enforce public health mandates, that doesn't have the ability to do that. And so you see not only interpersonal violence, but you also now see surge in COVID. And those two things are deeply linked. And so we need to be careful about the idea that the state doesn't have a role and where that goes and the logical extent of that. Yeah.
We're coming down in terms of our time. Let me read these two questions together. I think they're related. One from Rucha Patel. How do we address vaccine inequality for Black and Brown folks in the United States, I'm assuming, when we are also facing issues and fights about the concept of critical race theory? How can we address this within the public health lens? And this second question ties to it. Tying policy mandates such as vaccine mandates with human rights, how should governments and public health approach implementing mandates, especially when certain populations across the globe who have previously been exploited, well, I would argue still, but that's okay, previously been exploited and harmed by the healthcare system, and governments no longer trust those systems? So those are two easy questions for you to address in our final minutes.
Easy question. Just solve the debate over critical race theory and vaccines. So look, I think a couple of things, and I will be deeply humble and just say, like, I'm on the line with Dr. Linda Ray Murray, who I am fairly certain is far more competent than I am to answer this first question. But I'll play along and just say that I think the history of the United States as a place of deep injustice that is founded and has its economy founded on structures of white supremacy is just like it's increasingly understood, I think, by people in the United States. And I think we are making progress on understanding that. And we also are nowhere near done with that work. And the pushback I think we're seeing from the right against the idea of the boogeyman of a critical race theory that's actually a pushback against a racially conscious understanding of disparate impact in public health is deeply disingenuous, right? Because, I will just say that, like, I took a bunch of law school classes from people who pioneered critical race theory, and there's it's a caricature of it. But what it does tell us is that fundamentally, when we start doing the public health work, we can't start from the assumption that it is colorblind. That's actually it's just not accurate. And it will end us up in a place where we are like in Washington, D.C. for a while. When we first started our Washington, D.C. Efforts, they were largely based on pretending that all of Washington, D.C. was equal. Right? And pretending that what you could do is you could have equal access and therefore you would get equal outcomes. And we had horrific inequalities. And slowly but surely, the city council in Washington, for whom I actually have increasing respect for, they pushed and pushed and pushed until the health department focused the vaccine rollout. And they had entire days when only people from certain zip codes were allowed to come in for vaccines that were based on racial makeup. And that was smart because it moved moved us much more toward equity. And do you know what else it did? It drove down infections faster. It was good public health because they recognized race as a factor. So I'll just say that I think that that's critical, ironically, critical race theory. But I also think that there's this other piece that I think is coming in the second question, which is, to what degree? I mean, I've kind of talked a lot about my belief that the state should be used. And I'm saying that in part because I think we're in a place where the state is unused. But there is certainly another side of that, right? Which is the overuse of police power and the use of actual police to compel, and violence to compel people to act. And I think there we end up in a very dangerous situation. So when I say mandates are a good idea, I don't actually mean we should probably lock up all the people who refuse to take vaccines, right? I don't think that's actually probably a very effective way forward. What I think we've seen is that where you make it incredibly easy for people to get vaccinated, and increasingly you put pressure on them to do so, that most people want to learn the information and they want to get vaccinated eventually, right? And so, but that means making it incredibly easy, asking people again and again and again. You know, if we right now were in the United States and globally, if we were to invest the amount of money that we could do in public service information, plus the army of people to go out and talk to their neighbors about vaccination, we could be in a very different place. But instead, we've really done this thing where we've said, we've said it's a good idea, now it's up to you, it's in your hands. And I just think that that's the wrong message. If we look at some of the most successful vaccine campaigns around the world, they really are investing a large portion of their budgets in neighbor-to-neighbor conversations that actually help people do it, in local public health infrastructure to actually fan out and do it. And one of the things that we have found is that in several places, people have to be asked 10, 11, 12 times, directly asked, will you please take the vaccine? It's critical, here's why, before they do. And so if we know that people have to be asked multiple times, have we actually invested what it would take to actually do that? And I think the answer so far is no. Right? Most people haven't been asked 10 to 12 times to get vaccinated. They've, maybe seen a video on TV, maybe whatever. They certainly know it's out there, but have they actually been asked by somebody they trust? And so to me, that is where we go as we think about mandates, right? We think about kind of, how do you actually ask people as many times as possible? How do you root that in a human rights response that, to your earlier point, is about the state providing and making it incredibly easy, right? Is it true that every workplace has easy access to COVID vaccines? No. Is it true right now that every kind of, that everybody that's, every place where you would be required to get a vaccine, you can get one immediately? No. But for example, if you get off the plane right now in Puerto Rico, in Culebra, where they're trying to get international folks to come, you can literally get off the plane and get vaccinated in the airport. Why? Because we're valuing these folks who are coming on vacation and making it incredibly easy for them to just pick up a vaccine. Can we make it that easy every place? That's going to take a bunch more money, but I think that's where we're seeing success, right? And so I do think about places where, in Senegal, they're doing some really interesting things. In Thailand, they're doing some really interesting things to just make it incredibly easy. I'll say the last thing, which is just, there's been a fight around kind of access into HIV drugs for many years on this same paradigm. Do you force people? Do you push people? Do you criminalize the lack of pieces, or do you make it incredibly easy? And in South Africa, when they put HIV drugs into ATM machines and made it so that you could pick them up as you walked around the mall, their rates of HIV treatment access went way up. And so we need to do those kinds of things as we think about mandates. Really is there.
So, Dr. Kavanaugh, I just want to, we're down to our last minute or two. I just want to thank you so much for kicking off our series of forums. I love how you've placed not only the global lens on this issue, but really helped us understand the role of democracy, the role of preparation and intellectual property, and most importantly, the link between human rights and a human rights approach to things that need to go on in society and a pandemic response. And I'm confident that as we go in our series, looking more detail at COVID, that this first introduction you've given us will help us frame all of our discussions coming up. I want to make sure to invite those of you who are on this webinar to join us for our future sessions. I know our next one is with the president of APHA. And so we will be glad to talk about that. And I want to lastly say on behalf of health and medicine that this is a global pandemic that unfortunately is not over. And we are not about to be able to draw lessons from the pandemic because I'm not even sure we're finished with the beginning of the pandemic. We're certainly in the upswing in the midst of this pandemic. And if we don't think and have discussions like this, our ability to actually control the pandemic decreases. So again, before I turn it back to Wesley, I'm just going to invite you if you have any final comments to say.
Let me just say I'm deeply honored to be here. It's been really a great conversation. I really deeply appreciate that, and I just thank you to the organizers for inviting me. It is rare that we get to kind of dive into some of these issues for an hour and a half, and it's just been so. I have learned things from questions and enlightening, and so thank you very much for having me. I'm deeply honored and appreciate your invitation.
Well, thank you, Matt, for joining us. Wesley, let me turn it back to you.
Well, thank you so much. And thank you to Dr. Kavanaugh and Dr. Murray for the wonderful discussion. I know I learned a lot. I want to thank our audience as well for taking the time to join us and for contributing your questions to the discussion as well. Again, we'll send an email with a link to the recording after this forum. We'll send an evaluation of that email as well. You'll be receiving an invitation for the August 26th forum, which, as Dr. Murray mentioned, is the second in the series on COVID-19. That'll be at the National Perspective, featuring Dr. Jose Ramon Fernandez Pena, who is president of the American Public Health Association. So we hope you'll join us. Thank you so much and have a great evening.